So what is important is the illusion of stability in heart failure, the so-called illusion of asymptomatic patients. We do know from data that 20% or 1 out of 5 patients who is so-called stable, no prior heart failure hospitalization, already had a primary event. 17% of patients died during the course of the trial. And out of the stable patients who experienced a primary event, death preceded heart failure hospitalization in almost 50%. 60% of these deaths were sudden cardiac deaths. So the illusion of stability, we have to be able to identify and realize that just because someone didn't have a prior hospitalization doesn't mean he's going to be stable forever. These are the patients who have a high risk of sudden cardiac death and also pump failure. So therefore, ARNI should not be delayed and should be started as early as possible. It is important to note here that you need a 36-hour washout period when the patient is on ACE inhibitors before you start ARNI. So the American College has given these very strong recommendations for ARNI. And what they say is that in patients with HFrEF who are symptomatic, there has to be the use of ARNI to reduce morbidity and mortality, and that gets a class 1A recommendation. In patients who cannot use ARNI for whatever reasons, like angioedema or non-availability or cost, only then ACE inhibitors should be, and ACE inhibitors also are good drugs with the 1A recommendation. In those patients who cannot use ACE or they cannot use ARNI because of angioedema specifically, only then the ARBs can be used to decrease morbidity and mortality. And what is also important is that the use of ARNI has a high value in terms of economics as well. Even that statement has come into the guidelines. Now, is acute decompensated heart failure different from de novo heart failure? Now, if you look at acute decompensated heart failure, these are patients who already have the substrate of heart failure. They've had admissions before, they've had LV dysfunction evaluated before, whereas de novo heart failures have no other history. There are a lot of comorbs in patients with acute ADHF patients, where it is less frequent in de novo patients. The trigger events are mostly the medication, the compliance, infections, intercurrent infections, diet, excess salt, so on and so forth, and drugs. Whereas here, de novo heart failures, it most probably is etiological. Either it's an ischemic cause, it's inflammatory, could be COVID, or could be toxic. The clinical presentation is usually insidious in decompensated heart failure, while it is quite catastrophic and acute in de novo heart failure. The main pathology obviously here is the maladaptive neurohormonal state with a fluid excess, salt excess, and redistribution. Here it is primarily a LV pump failure in de novo heart failure.